Hello, my name is Michelle Proser. I'm the Director of Research at the National Association of Community Health Centers. I know a previous lecture covered the basics of community-engaged research and community-based participatory research. This presentation focuses on community health centers and how they are different from traditional office-based primary care providers, as well as their increasing importance and interest in serving as research partners. What I hope to show in this presentation is that health centers and their patients are unique, often excluded from research activities. I hope this presentation and the discussion that follow hone in on the reasons why health centers are ideal settings for translational research, research that is relevant to primary care generally and safety net settings specifically. The discussion questions that follow will also touch on the principles of community engagement. I want to quickly clarify some terms here. I'll probably use the term health center throughout this presentation, but generally health center and community health center and even federally qualified health center can be and have been used interchangeably. Although each term has its own nuances, generally speaking, I'm talking about those health centers defined by the Public Health Service Act, Section 330. But I think many of the lessons we'll see here speak to the special circumstances of many community-based organizations and safety net providers. The health center program began in the 1960s, or the health center program in this country began in the 1960s, I should say, back when there was no system of care to address health disparities, quality of care for underserved populations, or accessibility. It was founded by Drs. Jack Geiger and Count Gibson and based on a community-oriented primary care model that started in South Africa. Dr. Geiger will tell you that health centers were to be agents of care in communities with too little healthcare resources, as well as agents of change, giving communities control of their healthcare system. Health centers have a unique structure rooted in their program requirements. They're required to be located in or serve federally designated medically underserved areas and populations. They define health broadly and deliver primary and preventative services to entire population. They customize their care to meet the specific needs of the communities they serve, providing care in culturally competent ways. They provide dental, behavioral health, vision, and often pharmacy services. They're also required to provide enabling services, or those services that facilitate access to care and break down barriers to and address those root causes of ill health, things like home visitation, community health workers, translation, transportation, and so on. They also deliver care in multidisciplinary and team-based settings. Especially unique among all healthcare providers and even other safety net providers is the requirement that health centers be governed by a consumer majority board. At least 51% of those governing board members must be active consumers. Health centers emphasize community participation in controlling the institutions that aim to improve population health and community well-being. They're also required to conduct regular and formal needs assessments and participate in quality improvement activities. This includes identifying where gaps in care or unmet needs exist and where disparities in health care and health remain, and then matching the needs to the appropriate medical and public health intervention. Health centers have a long history in reporting structural process and outcomes measures that are often accredited by the Joint Commission, and many are moving towards patient-centered medical home recognition. Also of note, health centers have participated in a program called the Health Disparities Collaborative that applies the Wagner Care Model and Plan, Do, Study, Act, or PDSA cycles for chronic care management, and as well as other areas of practice improvement. And finally, most health centers have or will soon have electronic health records. Another important component of their healthcare model is that they're required to be open to all and to serve all without regard to insurance status or ability to pay. It's important also to recognize that many health centers are joining coalitions with other health center organizations. These entities, known as health center controlled networks, allow member health center organizations, each of which remain independent, but they come together to reach economies of scale for infrastructure such as health information technology. Given their unique model of care, it is not surprising that health centers serve a unique patient population. Most of their patients are uninsured or publicly insured. According to annual data that health centers report to the federal agency that oversees the health center program, Most of the revenue comes from Medicaid reimbursement and federal health center grants, but they are also reliant on a wide array of other resources, including state grants and other third-party payments. As the previous slide suggests, health center patients are disproportionately poor, uninsured, or publicly insured, minority, and sicker compared to patients nationally. They have higher rates of chronic illness, and studies show that health center patients often have lower or worse health status than the population nationally. More than 90% of patients have incomes below 200% of poverty. They also serve over 1 million migrant and farm workers and another 1 million plus homeless patients. About half of all their sites are located in rural areas. So you can tell from their 20 plus million patients that they're serving communities generally underrepresented in research and yet experience acute health disparities. As one example, there are very few sources of care and care data for uninsured patients. Health centers have doubled the number of patients served between 2000 and 2009. And thanks to the Affordable Care Act, we will see significant federal investment on the health center program as the Affordable Care Act creates a mandatory funding stream for the health center program on top of their annual discretionary base. The goal is to reach 40 million patients. Unfortunately, significant cuts to their discretionary funds last year means that 40 million patients will be reached after 2015. But the point is that health center program is rapid. I want to spend some time talking about a survey we conducted as part of a three-way community academic partnership. The NAC partnered with the local CTSA, our partners at the Clinical Translational Science Institute at Children's National in partnership with George Washington University, as well as the State Association of South Carolina Health Centers, the University of South Carolina as their academic partner, and finally the Community Health Applied Research Network, which brings together multiple health center research nodes, each with academic partners and a coordinating center. Last fall, the survey went out to all health centers except for those in South Carolina and Charn. Those organizations have now just completed their own survey of members using the same survey instrument but adding a long list of other questions as well. Findings presented here, therefore, do not include Charn or South Carolina and are preliminary. We had about a 33% response rate. For the purpose of the survey, research is defined as a systematic investigation designed with the intention of 1, advancing knowledge, and 2, publishing or otherwise publicly disseminating the results to audiences outside the local community survey. You can see that more than half of health centers reported that they do or have conducted research alone or in partnership with others. 41% said no. Of those that participate in research, when later asked if interested in expanding their research activities, nearly 70% reported that their health. Of those that do not participate in research currently, 14% said they are interested in leading research activities, and 40% responded that they're interested in partnering with external researchers. So among those health centers participating in research activities, most participate in partnership with others, especially academics. Of note, though, more than 1 in 5 health centers actually conduct their own research. A follow-up question asked whether health centers have ever partnered with external researchers. Nearly all replied that they had. When asked to broadly rate how they would classify the success of partnerships with external researchers, nearly all rated them either as successful or somewhat successful. Among the most commonly identified factors of successful partnerships, we find that health centers prioritize engagement of leaders and clinicians, the clear identification of roles and responsibilities, particularly through formal memorandums of understanding, trust and transparency, compelling benefits, the receipt of tangible resources, and that the researchers were familiar with the health center and the community being served. On the flip side, many research collaborations experience challenges. Among those that health centers reported, the most common had to do with constraints to staff time and budgets, lack of true partnership or engagement, and failure to get to know the community or the center's priorities. The survey also looked at several domains of research capacity. Some centers have staff whose time is covered fully or in part by research grants. The roles health center staff play in research activities are varied, but most often include recruiting research participants, collecting data, and implementing the intervention. Less common activities include developing research reports or manuscripts, managing research findings, conducting data analysis, and interpreting findings. Nearly half of health centers report that they do not make independent use of an IRB. This implies they tend to rely on IRBs of partner organizations. In order to help break down the barriers that inhibit research participation among health centers, the survey asked health centers to rate a long list of potential barriers. The ones here are the top ones presented. For analysis purpose, we combine barriers rated moderate or large. Among the top are concerns about the cost and care consequences of diverting staff from patient care in order to participate in research, lack of funding or ability to seek it, and lack of know-how in terms of publication, data analysis, participant recruitment, building a data infrastructure, and other concerns about where to begin. Because I feel these rankings are so telling, I'm going to add a few others. I'm adding basically all those that were where at least half of health centers rated them as moderate or large barriers. So other barriers of note include concerns over accessing partners, getting staff buy-in, and ethical review. We also wanted to see what motivated health centers to engage in research activities. Again, we combined moderate and large rated items. Health centers overwhelmingly rate improving patient health and health care as important benefits of engaging in research. Other top-rated items include non-research related benefits that come with partnerships, such as additional resources for capacity and support for things like assessing patient experience or supporting quality improvement activities. Anecdotally, we at NAC frequently hear from health centers that are most interested in research that not only addresses their high-priority community health and organizational concerns, such as practice transformation under patient-centered medical homes, but also leaves them with tangible resources. This is what health centers are really looking for. These may include access to new staff, be they or staff resources, be they physician specialists, medical assistants, health educators, or community health workers. They could also be patient education tools or IT support. Our national survey demonstrates that a substantial portion of health centers are already actively engaging in research, most often in partnership with academics or others. Most of them are eager to expand their research enterprise, and many other health centers are eager to get started. The research findings suggest that health centers see research as a way to build on or meet their missions for improving access to care and minimizing or even eliminating health disparities. It's also important to keep in mind that community engagement is natural to health centers and a prerequisite to their participation in research activities. The bidirectional nature of community-engaged research, such as CBPR, is the best way to address the contextual factors in which safety net providers like health centers operate. Health centers are eager to participate in the creation of new evidence-based practices, spread generalizable knowledge, and benefit from research conducted with similar patients in similar settings.